general review of movement emergencies. So this is acute Parkinsonism. After chemotherapy, he has gut wheeling, as you could see there. You saw it right there on the way in. And of course, severe akinesia.
Wiggle your fingers.
Carlitos, mueve los fingers. So after a little bit of Cinemed, then he starts moving a little bit more.
Squeeze hard. Squeeze hard.
We just have a patient in the hospital in the cancer center with exactly this.
Good. Open and close your hands.
With a new chemotherapeutic regime. But as you can see, residual Parkinsonism. Let's look at this. So abductor paresis on the MSA. That's how Strider sounds. So you have multiple levels of paresis. This is some information from Japan, some videos from Japan. They're very good at MSA. I mean, PD plus signs in syndromes in general. So you see how the opening is incomplete. Stage 1. The patient is awake, but the whole cords are completely separated. So it's completely, it separates fully in between air movements. And that's exactly what they are saying right there.
In Japanese?
But normally, you shouldn't see them all next to each other. You know, they should be very separated. And here we are gonna see, again, they're very close, but then at the very back, they are never separating fully. So all of that continues to get worse and worse and worse, and getting phone calls from the hospital. At this stage, the patients are almost unable to breathe. It is extremely uncomfortable. Danish, do you want to finish reviewing some while I answer
videos?
this?
Yeah. Switch quickly.
Was it in the journal?
Yeah.
Jumped over the lazy
This is the journal of...
Send it to me so you think of it ever.
Close your eyes. Open.
we start the chapter,
Open.
Danish. So that's the... you go on the top where it says select chapter. No. Yeah, start video.
Chapter 1?
Start video first. And then you go to select chapter. That's where you select them.
I see.
So the
acute Parkinson's.
The number 7 is the acute dystonia. Be right back.
Grand Fox jumped over the lazy dog. Good. Close your eyes. Open. Close. Open. Show me your teeth. Can you stick your tongue in and out? Stick your tongue in and out. Okay. Can you open your mouth wide as you can? How's your jaw feel right now? Okay. How you feeling right now? You're feeling a lot better.
Speech
This is about a minute later, right? Can you repeat that sentence for me? Great. Speak your tongue.
You saw how hypernasal this speech was, almost like they call it hot potato sound, as if you're hot potato more than you're really burning, and you're freakingly trying to do what to do with the potato. So it was probably because of jaw opening dystonia. So they have a very effortful speech, and they really have to try to clench the teeth, but they still cannot do full articulation. Remember, when you're trying to assess the speech sound itself, you have to divide it into phonation and articulation. So phonation is what's happening in the larynx, like what Diego was showing earlier, the closure or lack of closure of the vocal cords, and that's where the phonation and back of your throat is being produced. But the articulation is the movement of the tongue, the jaw, and the lips. And any weakness there will produce a dysarthria, which is very different than dysphonia. And that's what you have to slowly start getting used to. So what he was having was dysarthria, where the articulation was not happening. Where he was trying to close the jaw, but the jaw is not closing. And it was making very effort. And then now the speech has improved after receiving. So acute dystonic reaction, what is the most common or classic acute dystonic reaction? Retrocollis. So retrocollis is the most common and most acute dystonic reaction. He has a slight retrocollis. Initially I was wondering if the camera was up high, the guy speaking to him is standing. That's why he's looking up a little bit. But I'm not so sure anymore. But that could still be the reason. And it may be that he has a segmental dystonia with the neck and jaw and lower face involvement. What's the most common cause of acute dystonic reaction?
I was going to say medications, but I'm guessing you're looking for a specific one.
It used to be metoclopramide up until 5-10 years ago. Fortunately, has come down, and now the dopamine blockers are the most common cause. The psychiatric antipsychotic medications, Haldol, I think, is now the most common cause. It's still being used for agitation with an acute dose, and it's the acute exposure that causes acute dystonic reaction. Acute re-exposure is also very important phenomena to remember. So a lot of time patients come into the ER after missing 2 days of medication, intentionally or vomiting or throwing up, being sick, and the ER guys say, let's start home medication, and we give him the dopamine blocker. The patient can have acute dystonic reaction. What is the second most common, or let's say most important acute dystonic reaction to remember? Oculogyric crisis. So it's an acute ocular dystonia, and for some reason is classically associated with sense of fear, but I think even retrocollis has an associated fear with it if it's an acute dystonic reaction.
Probably fear because of dopamine blocker.
That I'm not sure, but it could be because of the limbic system. You know, you have a dopamine needed for outgoing personality, and now he's suddenly withdrawn, which maybe the fear is.
Okay, something just happened, didn't it?
He still has slur. You hear that? He has this lisp, and I think that's the most commonly missed abnormality in voice, is that kind of a sound, lisp, which is the weakness, which is I see it more with dystonia, but it can be from ataxia, it could be from tongue weakness. But a lot of time when I walk into the room and the patient starts talking, it's this kind of a sounds, they kind of they stretch, the Z's and S, but anything that requires articulation is being stretched is one of the most common thing that gets missed. So this is dystonic storm, which is a status dystonicus is another name. It's like severe generalized dystonia. I'll show you a case where we admitted a patient who was in a dystonic storm. Very similar. Patient in her 20s with history of cerebral palsy, dystonic cerebral palsy, and she was on baclofen pump for treatment of generalized dystonia, and that baclofen pump was cut down more than half, thinking that she was having increasing dystonia, and they thought it was because of the baclofen, so they cut it down, and she had even worsening of dystonia, and she was like, this neck was back like that, opisthotonus, a pretzel like that. And I have videos in some of my lectures, or otherwise I'll show it to you. We admitted her for status dystonicus, severe generalized dystonic spasm going on continuously. She was in it for like 6 to 8 weeks or something. And we treated her with IV Benadryl, then Cogentin, clonazepam, a lot of drug to try to break it.
So you're not better learning fluent?
Is Benadryl available here?
Yeah. Fortunately.
Your local drugstore.
Okay, dystonic.
It's not available in Pakistan.
Really? IV or oral? Both?
Both.
So very good drug.
Yeah, it looks like cheap and effective, but it's not available.
We saw these malignant phonic tics. Let's see that one. So there is a tick storm, similarly to dystonic storm, or you can call it status dystonicus. So there's a status for tick status, which is sometime happen. Again, it's usually either drug induced or drug withdrawal.
So we see one of these maybe every 5 years.
Fortunately, unlike failure where they see once a month
Once
or a
a
week
day.
or
Yeah. So they see a lot of these. I think in part is because overuse of antipsychotics.
So you do have this warning.
So there is a lot of
What kind of words might you speak?
concern about the use of antipsychotics in our institution for tics, because we have a feeling that they could induce
What kind of things are you
more
unable to do
malignant
because of this
tics,
screaming?
tardive tics, and worsening of behaviors. We see a lot of patients with Tourette syndrome. I think I see more than Danish
definitely.
and Danish more than the rest of the faculty. But all I do with the tics is get rid of the
Yourself, have you
medications,
ever noticed any
and they slowly get better.
movements,
So
any particular
it's sort of a
habits or things?
sort of a
that you notice?
sort of a pain. That people tend to give more and more medications to these kids. Basically, we just eliminate the medications. Okay, so this is a dystonic tic. Dystonic tics are tics which posture is held for at least 3 seconds. And of course, dystonic tics like that need to be admitted so that we can treat them. And we treat them in the same way as dystonic storms. Sometimes patients that have relatively mild tics but that are fully incapacitated by the tics then need to be admitted so that we can start treatment right away.
Now,
because of these sounds, these noises,
So he's a math teacher, I
understand,
think, or something.
you have not been able to go in public, is that right? You cannot.
Well, I can, it disturbs others. My wife pointed this out, and made a point to try and not go to things such as my son or my daughter's award ceremonies. My son's baseball games, things of that nature.
So it must be very frustrating for you.
No.
I like that he hadn't noticed that this was disturbing to others until his wife pointed it out.
Yeah. It's, it's very, 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 very problematic condition. Now this one I'm not sure about. Anyways, a few malignant phonetics, we will review that later. And then let's just review Whipple's disease and we will call it a day.
We will illustrate neuroophthalmic signs that are highly suggestive of Whipple's disease. When all three are present, it is pathognomonic for this condition. These are pendular vergence oscillations, rhythmical myoclonus, vertical supranuclear ophthalmoplegia.
This particular thing, rhythmical myoclonus, do you know anything else that can be called a rhythmical myoclonus?
Palatal tremor?
Yeah, so palatal tremor, physiologically speaking, is a myoclonus, but it occurs in a rhythmical fashion, so it is, best described as rhythmical myoclonus. Another thing that is interesting is that the classic tardive, the old term, previously called classic tardive dyskinesias, which is the tongue movements, the tongue protrusion, and the lips smacking and the like, also used to be called classical tardive dyskinesias, and now we're changing that more and more into tardive stereotypies, as they seem to be stereotypical movements. They seem to be able to hold them, they seem to be able to, when they're talking, these movements go away, so, they seem to be under full control of the motor system, and therefore then not involuntary but involuntary movements or semi-voluntary movements. Anyway, so you guys know vertical supranuclear ophthalmoplegia, right? So you're unable to look upwards, but when you move the head, then the eyes move. The pendular vergence oscillations, so you know what that is, David?
It's the, I don't know how to describe it off the top of my head.
Okay.
It often goes with the jaw movement.
Well,
with another name.
that's more here.
The first sign is pendular vergence oscillations, which are continuous, smooth, rhythmic, convergent eye movements with a frequency of 1 Hz, varying from 1 to 25 degrees of amplitude per eye. Pendular vergence oscillations by themselves are highly suggestive of Whipple's disease. They may be so subtle that extremely careful observation may be required. They may be asymmetrical. They may continue throughout sleep. They never diverge beyond the primary position. Divergence and convergence are at the same speed. They are not accompanied
That's
by
why it's called
capillary
pendular,
meiosis
not a nystagmus.
or accommodation.
But the most important thing is that there is no meiosis.
Yes.
Okay, because if there is meiosis, then
It's like voluntary,
it's voluntary and therefore
Vergence.
psychogenic.
right?
very important. On these, I usually just look at the nose and then get a feeling
This
for what the
patient
eyes are doing.
illustrates
If you look at
how
one eye
subtle
versus
and
the other, it's really
asymmetrical
hard.
these pendular vergent oscillations can be. Sometimes, opening the eyes after forced closure may intensify the oscillations.
That is something I have never seen. But there you go.
Yeah. I could not see anything before. Just now.
Beautiful.
The second sign is rhythmical myoclonus and is characterized by a repetitive contraction of the facial, masticatory, and pharyngeal muscles, which may extend to the limbs. This patient with Whipple's disease demonstrates bilateral, asymmetrical, facial, masticatory, pharyngeal, axial, and limb myoclonus.
It is a lot slower than the typical myoclonus that you would see. So. Okay. Well, I guess that's it. So we'll do another roundabout for the chronic ones and go from there. We're right in the middle of the presentation.